Okay. Well, thanks for allowing me to insert myself into this very interesting echo. I've been involved in the state opioid response grant now for the past year, and a big part of the grant for us in the Division of Physical Therapy is to get the word out about the various roles for physical therapy with the opioid crisis. So today I'm going to kind of give you an overview of that and hopefully broaden your horizons a little bit. Okay, so can I?
Yes, absolutely.
I did some transition, so I'll drive the mouse here a little bit. So messaging in the U.S. Domestically is through our national organization, the American Physical Therapy Association, which created this campaign called the #ChoosePT campaign. And so when the CDC guidelines came out really recommending that physical therapists should be one of the frontline people involved in trying to do a better job of managing pain, they created this whole public service campaign. So you may or may not have seen that, but this is a whole spectrum of that Choose PT campaign. So we're looking at highlighting how earlier intervention might be able to prevent progression toward heroin usage, misdirection of medications, particularly affecting the elderly, mental health issues, and the big one that we always run into is the management of low back pain. But another one that they recently came out with that may not be on your radar as far as a physical therapist's role in this crisis is in dealing with babies who are born addicted and going through opioid withdrawal. And outside of the U.S., this is an issue also for the global organization, which is the World Confederation of Physical Therapy. And on World Physical Therapy Day, earlier last month, these were some of the infographics that were put out. And I realize those are quite small, but basically highlighting that pain is not necessarily tissue damage, and that inactivity and bed rest is not necessarily the appropriate approach to manage common pain issues. Again, focusing heavily on low back pain as it's such a huge issue, but not necessarily that. And on the right-hand side of the screen, that taking control of pain, the little stick figure is talking about kind of how physical activity and being active and having a good strategy for that can really help improve function and quality of life in people who do have pain. So what I've put together is not nearly as pretty, but just sort of schematics here and looking at where we can play a role. So I think physical therapy is one of the few places where we're really looking at prevention of the opioid addiction thing by managing pain non-pharmacologically as much as possible. And so across the opioid addiction spectrum, looking at alternatives to opioids. So let's not get started down that path if we don't need to. In people who do need opioid type medications, and we know there are some of those, playing a role in the co-management of those pain conditions. So appropriate opioids plus physical activity and task modification and energy conservation and all of those types of things. And then in recovery from addiction, that's a growing niche practice, is having physical therapists actually involved in inpatient addiction recovery centers and looking at musculoskeletal things, but also a lot of that being healthy lifestyle and physical activity and how to begin to do that kind of take charge of life. And then you see in the purple box there that pain education. What is pain? Why do we have it? How does it work? How do I manage that? Is a big part of how we would approach the patient dealing with pain. So I put together a little bit across some of the diagnostic areas. So chronic pain conditions are sort of musculoskeletal, and these pop up kind of the size of the bubble is sort of the scope of the problem. So certainly neck and back pain is probably the biggest group of people that have those chronic pain conditions. But arthritis, both spinal, but also in the extremities there. Chronic pain conditions such as fibromyalgia, that's certainly in the musculoskeletal realm. Headache, and temporomandibular joint dysfunction is another chronic pain condition that we'd be involved with. Chronic regional pain syndrome, which used to be called shoulder-hand syndrome, reflex sympathetic dystrophy. Again, we can be involved in that kind of situation. And maybe one you haven't even thought of. I work as a cardiopulmonary specialist and work with people with chronic lung disease, and oftentimes they complain about chest wall pain, and obviously putting those individuals on narcotics is probably the last thing we want to do for someone who already has a breathing problem. So are there musculoskeletal things within the thorax and chest wall that could be addressed? Another area I work in is oncology rehabilitation. So less commonly recognized things like maybe post-mastectomy pain syndrome. Again, are there non-pharmacologic ways that could intervene or at least decrease the need for pain medications? Chronic pain prevention. So that is looking at people who already have chronic pain syndromes, but there are roles that we have in preventing that. So with surgery or trauma, the early mobility kinds of approaches, getting people up and moving and helping to deal with their pain in appropriate ways there. Preventing opioid use for sports injuries, or preventing the sports injuries to begin with, but certainly the athletes and youth is a target area that we want to try to avoid going down that opioid route. So areas that we can look at non-pharmacologic acute pain management to help prevent progression to chronic pain. Looking at lifespan issues, excuse me, some areas that physical therapists are involved in that you may not be aware of. I think lifespan begins prenatally, actually, and so addressing mother's pain conditions as her body changes during pregnancy. So that's an area of practice for us. I alluded to the neonatal abstinence syndrome in newborns, and we'll talk a little bit more about PT roles there. But as that child then grows up, we're beginning to find that there are behavioral and developmental issues in those babies. And so physical therapists that work with children in that setting can certainly begin to address that. And then moving on into adolescence, that's an area for sports injury in our very active adolescents, and certainly an area for trauma of all types. And so again, we can have a role in addressing those and helping preventing that progression through to chronic pain and inappropriate drug choice there. Going backwards under maternal care, sometimes there are long-lasting pain conditions associated with pregnancy or multiple pregnancies, leading to things like chronic pelvic pain, chronic low back pain. And again, our physical therapy can work there. So the green star is kind of to look familiar. A lot of it has to do with healthy lifestyle. We know we want to get people active, but how to work with all of these different issues across the lifespan and unique situations. On the other end of the lifespan, some chronic pain issues in the geriatric population. I mentioned spinal issues, back and neck pain, arthritis kinds of issues, but also the geriatric population that has joint replacement or other types of surgeries there, spinal fusion. Again, we'd be involved in helping to prevent that progression to chronic pain. And in the cancer population, one that's not as well recognized is the issues of chemotherapy-induced peripheral neuropathy pain. And that's a big question mark right now, but we certainly know that we can intervene to make quality of life and function better, whether or not we can really impact the pain directly. So again, the healthy lifestyle and physical activity approaches to this, and in the geriatrics, trying to prevent down the line fall-related traumas that, again, can lead to disability and pain conditions. Women's health pain conditions, again, across the lifespan at the top. So in adolescence, girls, sports injuries, tend to be different risk factors, different recovery, maybe even different access to good training issues, so we can intervene there. Issues related to menstrual pain and endometriosis in young adulthood, pregnancy-related pain, postpartum pain. Into middle adulthood, more the chronic pelvic pain issues that our pelvic floor physical therapists can certainly play a big role in that. But across from middle adulthood to aging, as a woman goes through menopause, there's often flare-ups of things like the arthritis type conditions that, again, this healthy lifestyle can really play a role in that. And then in aging, cancer is more of a condition of aging, so we might see it there. So physical therapy is a profession that specializes in understanding human movement. So the model in the middle, that is the intertwining of different types of body systems, is our national organizing model. The physical therapist is an expert in human movement, and it involves all of these different systems, and why we have to understand the function of all of these different systems in leading to a movement of an individual. But the 5 boxes around this logo are my own additions in looking at what are the components of movement, from strength, endurance, flexibility, balance, or agility, and also the things that I like to say happen between the ears. All of those factors about motivation, fear, fear of pain, past experiences, embarrassment, all of those kinds of things. So, we have to assess all of these when we're looking at optimizing someone's movement ability. So we do individually assess all of those kinds of things. And then physical therapy is a profession rather than an intervention, because what we do is very, very individualized. But looking at pain conditions, certainly education is a very big part of what we do, working with individuals, teaching them about pain, how it works, what this is, the neuroplasticity of the brain, all of those kinds of things. And then about movement. Why is movement important? What kind of movement should they do? How do you start? What do you watch out for? All of those types of things. So we develop this personalized movement plan, which may involve graded exposure. So very much out of the psychology literature of things like phobias. But if fear of movement is a major limitation for people, then having them try a small movement with supervision, with coaching and encouragement. Look, you did that, it was okay, it was better than you thought, so let's practice that. I like to describe what I do as being a coach rather than a mechanic. I'm going to analyze your motion and what it is that you need to do to perform in your life. I'll give you lessons to practice, and then we'll come back and do another lesson and see where you are. Whereas a mechanic says, drop off your car to me, I'll fix everything and come back and pick it up at the end of the day. So it is very much that integration with the patient and that working together. If we discover that there are deficits in strength, endurance, flexibility, etc., then we work on how can we remediate those deficits. And then looking at the whole person and their overall physical fitness and ability to perform the movement that's purposeful for them to participate in the things that are important in life. So wrapping up here, in summary, the opioid overuse is not just a problem in West Virginia, in Appalachia, in the US, but this is becoming a global issue. Starting to see data coming out, reports coming out of Australia of narcotic overdoses. And, they say, don't learn from us, or learn from us and don't go down the same path. But it is becoming a global problem. Physical therapists are and should be a part of the team for both prevention and minimization of opioid use, as well as recovery from addiction. Every patient that sees a physical therapist gets an individualized assessment and plan. So when someone says, well, what would PT do for low back pain? It's a huge spectrum. It's very much depends on the individual. Pain, both acute and chronic, and its assessment and treatment is part of entry-level education as required for all physical therapist education programs nationwide. But we do struggle with access for our patients to access physical therapy. So it is both geographic, where are we located, but a lot of that is financial. So it may not be widely known that physical therapists can perform at least evaluation and often treatment to begin without a physician referral. And that avoids the delay. It also avoids unnecessary imaging and unnecessary other types of tests, so cost-saving types of things. So you all can help spread the word that if you're having pain, yes, you can go see a physical therapist. We're well trained to know what we can manage and what we should refer out. Okay, those red flags kinds of things. And so that's possible in all 50 states. However, CMS, which is, you know, the major driver of all kinds of things financially, does not recognize that. And so it does require those extra steps of a physician referral. So that's a limitation. The other limitation that we fight is the issue of copays. So it may be anywhere from $30 to $50 or more per visit copay to see a physical therapist. So in our population here in Appalachia, that's a big barrier. So, you know, our organization's working to address that, but I think the more we can get the word out from that, the better. So I'd ask you to help spread the word on that, what a physical therapist can do, how our patients can access that, and also to help say, you know, if we want to cut healthcare costs, please, we can decrease the number of very expensive imaging tests by, you know, using us as that screening kind of approach. So I'll leave you this slide here on the screen really quickly, just some key references about physical therapists' role in the opioid issues and chronic pain issues, and the websites that I referred to. So I'd be happy to take any questions.
Thank you so much. That was wonderful.
Thanks.
And my apologies for being late. I got tied
That's
up
okay.
at Ruby. So.
That's all right. Understand.
So if I have a question.
Yeah.
So if a physical therapist is allowed to initiate the initial treatment and anything subsequent, is still going to require a physician referral.
That is very much state by state. So each state licensure. In West Virginia, we have had unlimited direct access since about, I think, 1984.
Okay.
So we were one of the first states to be able to do that. So we do not need a physician referral by law, by scope of practice. You know, again, certain payers will put that limitation on there. Medicare is notorious. You develop a plan of care that has to be co-signed by the physician. You have to do that back every 30 or 60 days. But we're making some inroads with some of the private payers because we've had evidence published that having PT first, especially for conditions common like low back pain, can significantly decrease costs overall to the health system. So starting to make some inroads there.
If you had to rank common chronic pain syndromes amenable to PT, how would you rank them from best to not so good?
I would definitely say low back pain, neck pain, things kind of targeted on joints like shoulder, knee pain. Then you get into things that become a little bit more difficult because a lot of the psychosocial overlays, such as the chronic fatigue, fibromyalgia types of things, but again, just a little different strategies with that. But I think we're really good at the back and the extremity joints quite a bit. Yeah.
Thank you.
Do you guys have any questions? I had one about the babies. What kind of physical therapy is done for infants?
So physical therapists that work with young children, it is all about normalizing development. So babies who are born addicted, their sensory inputs and all of that is changing. So a therapist would be sort of consulting about how do we make this a more normative environment? How would I work with, say, the baby's mother to swaddle and cuddle and breastfeed and those types of things. Once we're in the home setting, there are therapists that specialize on birth to 3, usually in the home intervention. So it's, how do you get through those those normal developmental milestones in the context of the family and family-centered care in conjunction with the child's, whole medical team with that.
Cool. Thank you.
I have a question.
Yes.
I was wondering about your thoughts about motivation and movement in patients with chronic pain.
Okay. Yes, motivation is a big term, as I'm sure you're aware, and so I think we have to get to what are the barriers specifically. Is it that I tried moving before and I hurt, or I tried moving before and I set my goals too high and I couldn't accomplish that, or nobody in my family has ever exercised, so I don't know why I should. And the approaches to that would differ depending on sort of what those individual barriers are. But I think it's that, if we can build that therapeutic relationship and say, okay, are you willing to try? I know this is, that maybe you failed in the past or you don't think you can succeed. Let's try. Let's set our goals very, very low. And when you accomplish that, be very encouraging to this, setting the goals. It's much like weight loss. Somebody needs to lose 50 pounds, and because they can't lose 5 pounds a week, they give up. We know 1 a week, or even a half a pound a week is appropriate progress. And it's just keeping that encouragement going of when you see that. Or if someone says, well, yeah, I tried that movement, but now my knee hurts. Okay, let's look at the biomechanics of the knee and the situation in which you did that. Is there something we could alter that makes that now a more successful experience for you?
Okay, thank you.
The second word of physical therapy is therapy. So my psychology colleagues on the call will appreciate that we steal a lot of your stuff. Yes.
Speaking of stealing, this is Mark at the Pain Clinic. You guys stole my question when it came to the babies with NAS. One thing I would just add in there, because my patellar response kicked in when something was said there, and I don't have an L5 problem, but that the terminology with the babies, it's usually going towards the idea of dependent on opioids, not the addiction idea. I know that one kind of, trust me, it comes off, well, I don't like to say it. I'll say it has never come off of my tongue, but it probably has. Just throwing that out there because we're in an echo thing. So.
Thank you, Mark.
But thank you for stealing my question too.
I stand corrected.
Great. All right, guys. Do you guys have any other questions about this or anything? And we thank you so much again. That was great.
Oh, you're welcome. Yeah. Give me a platform and I'll talk.